foreign bodies, right? So this is our non-infectious stuff. This can be pretty scary. Burns, anaphylaxis, trauma, anything that causes obstruction of our airway. So if you have a scenario where a child has choked and they have partial foreign body airway in place, what would they be doing that would make you think it's not full obstruction? Coughing, making noises. They have stridor. The stridor is like some air is passing, even if it's not a lot. So if they have partial obstruction, again, we don't want to upset the child. Like, don't take the sleeping baby. Don't upset the airway obstructed child. Allow them to keep coughing because they're trying to clear stuff on their own, and that's great. However, like you do for so many scenarios, which you are amazing at, is be prepared for the disaster situation. Be prepared for the disaster situation before you're in the disaster, right? And then it'll be nice if you don't have to do all the bad things that you're prepared to do, and they clear the thing on their own. They may have some pretty funny breathing patterns. You might have that tracheal tug, right? Which is that pulling at the base of the neck if they're trying to get air in. The complete obstructed guys are different, right? They're not making sounds. They aren't able to make that stridulous noise. They may or may not be having adequate movement of their chest. They might do things that indicate I'm really stressed and struggling here, like the kid holding their neck, infants raising their hands over their head. Usually the infants will be like bright red or purple, often is what you hear from families. When you have an upper airway obstruction, you want to do the back blows and chest thrusts to try to dislodge that foreign body. In an older child, it's going to be abdominal thrust, like the Heimlich maneuver. And then if they become unconscious, then that's when you're going to be thinking to start CPR. If you have McGill forceps and pediatric ones for your smallest patient population, you can get a good look in there with direct laryngoscopy. If you can remove that foreign body, rock on, no blind sweep. Don't ever stick anything just blindly into a child's mouth that might have something in it, because then you might create a full obstruction. So that's a bad idea. If you still think that that object is in place obstructing the airway, you can't see anything, then you can try to intubate from above and push that thing further down. Which is what we see here, right? So if you have some Barbie shoe, I don't know, that probably wouldn't obstruct the airway. Let's say something that obstructs the airway. And you're able to advance that endotracheal tube to push that object into one side of the lungs, great, because they can still oxygenate, ventilate with the other side. So that's what that looks like. If you do that and you don't have, you still can't ventilate, then what might be going on? Could you have a tension pneumothorax? Maybe. Hopefully you'll be able to tell that clinically, so you can needle decompress. These needles are going into an area that we don't typically do for pediatric patients. So where do we typically needle decompress for pediatric patients?
Or second and third intercostal.
Right, so mid-axillary second intercostal space. So I think it's just a slide that is inclusive of adults as well, but we don't go down here for kids. All right, so possible main stem with a pneumo. What happens now if you have advanced the tube and you still can't ventilate? Then we think, oh geez, is this like really bad luck? Do they have obstruction in both airways, double Barbie shoe? That's a problem that you can't solve. So that's, transport quickly. That's like a cardiothoracic surgeon open chest type of situation, which we're not going to be able to improve either.